All right, so ICP or intracranial pressure. So pressure is high. It's high in the brain. So why is it high? So usually there's something in the brain happening, one of three things, might be a fourth thing that's getting out of control, right? So we'll talk about those things, and to get rid of that ICP, we can just stick a fork in it and we can pull out some of the fluid, right? That's one of the things. One of the things is CSF, right? CSF is one of the things that gets made in the brain. It's around the brain, it's made in the brain, and we can take out some of that stuff, and that will relieve the pressure that's building up inside that skull, right? So we'll talk about the CSF, we'll talk about the brain tissue itself, we'll talk about the blood volume that's there, and sometimes there's a mass that's developing, right? A tumor or a cancer that's developing as well, right? That we'd be able to fix, or even an abscess. Okay, so please stand back, my head is about to explode. So intracranial pressure, again, it's three things: the brain volume, the CSF volume, and the blood volume. All these things are interacting inside this closed space inside the skull, and if any one of them get out of control, our body can only compensate for so long, right? So if we look here, we can see our body's compensating until it's exponential, where your eye speed jumps up immediately, right? And you want to catch it before that happens, right? This loss of compliance. When we look at our waveforms on the monitor, you're going to see the waveforms start changing. So I have a normal waveform. I can't even draw a normal waveform because it keeps erasing it. Well, shoot. Well, that's not even working at all. Sorry, so she's a different color and draw again. So, oh, now it decides to do it. Anyways, that was a joint effort. So it got to, I can't erase. Why is it now erasing? One. Oh, perfect. All right, so yeah, so that's a normal. You got like a little stepwise reaction. Oh, okay, now it's gone. So anyways, you have this, it's fun. All right, but after a while, you're able to see that the P2 is higher than P3. That's a loss of compliance. When we talk about waveforms, you'll be able to identify that the waveform is getting worse, right? And you're in this danger zone right here, because after that, it's no man's land. It's now the ICP is going to shoot up dramatically, right? Exponentially, if even, right? The pressure goes up. This is called the Monroe-Kelly hypothesis, right? So Monroe-Kelly is the guy that invented this. Say, hey, you got three things, and if the three things go up, the pressure go up. It's like, oh, Nobel Prize, yay, right? So yeah, so that's what we're looking at, right? So we have a lot of brain volume. About 80% of it is brain volume, and then we have CSF, right? That's another about 10%. And then we got blood flow, which is another about 10%. We need to get the adequate blood flow, otherwise we're going to get cerebral edema, right? Because you're not going to get the oxygen or glucose that you need. And you need a good blood pressure, because now it's going to deliver the oxygen or glucose. So we need to have that good blood flow as well. Too much blood flow is a problem. You can't take out blood volume. That's not usually what we're doing. We're not usually taking out volume of blood to fix someone's ICP, but we can improve venous outflow, right? Because our brain drains, right, via the jugular vein, it drains here. And if our neck is not midline, our neck is off to the side like this, now we're going to be compressing the jugular on the one side, and now it's going to start backing up into the brain, right? So if our guy his neck was off to the side like that, then it's going to start, all that CSF's not going to be able to leave via the jugular system, and it's going to start backing up and raising the pressure in the brain, right? So CSF is made at a constant rate of about 150 mLs per day, to about 250 really, somewhere around 200. And sometimes we want to make sure it's draining, for one, out the jugulars, but also sometimes we can stick a fork in it, right? We can stick a little catheter in it, and we can take out some of that CSF, right? We don't take out blood, we take out CSF. And you don't scoop out brain either. If someone's ICP is too high, oh, I guess you don't like you want your memories from your childhood. Let's take that out as well, right? Do you like talking? Let's take out the Wernicke's area in your temporal lobe. You like seeing? Let's take out the occipital lobe. We don't do that. But what we will do is take off a piece of the cranium. Let's crack this open and pop it open. And now that's called a decompressive craniectomy, where we take off a piece of the cranium and to allow the brain to expand. When you see that, that's the last thing we do, and that's not a good outcome when you have that. The mortality is like almost 70% at that point, right? So any one of these three things can increase in size. I can have more volume of brain, right? That's like after this class. I got cerebral edema, right? My brain's too big now. But no, what had that happen? It was the cerebral edema that happened, right? They had an anoxic event, they had a hypoglycemic event, they had a cardiac arrest. All these things made them edematous in the brain, whether it be a stroke or something at the blood-brain barrier not working good to keep back all the fluid that should be kept back, right? So my volume of brain could go up, the CSF could go up. How does that happen? Well, it could be drainage, right? Because we know that CSF is made and then it leaves, right? But how does it leave? There's a little piece, little pieces that stick down into the sinus up there. They're called subarachnoid villi, and they sit in the subarachnoid space, and they take CSF and they pull it into the venous system, right? If those get clogged, then now the CSF's backed up, right? So they have increased CSF volume at that point. That's called a hydrocephalus, right? A communicating hydrocephalus technically. So someone that has blood, for instance, they have a subarachnoid hemorrhage, and they get blood that's building up in these areas, it's going to start blocking those little channels and backing up, and now the CSF's backing up, right? So CSF is something we can fix, and CSF is something that can build up over time, and we'll talk about those. And then the blood volume can go up, right? So the blood volume could be a bleed, straight up, they have a hemorrhage into the brain. That's why the blood is increased, right? So we can adjust the blood volume, maybe. We can take out the hematoma, we can take out those things, but really we're looking at the flow into the brain, right? We're adjusting the arterial blood volume. We know that the blood volume will be increased if we vasodilate. If we vasodilate with like hypercapnia, right? So when CO2 starts going up and up and up, you start getting vasodilation within this cranium, and that's going to raise the pressure in the brain, right? That's going to increase the blood volume. One of these three components that gets increased, your ICP goes up. So how can we avoid that? We can avoid hypercapnia. How do you avoid hypercapnia? Use every opportunity you want. It's the 5 Ps, right? You go in the room and say, oh, position, potty, hypercapnia. We want to avoid that, please, okay? Hit your call bell if you feel like you're getting hypercapnic. So how do you avoid hypercapnia?
Increase the respiratory rate.
Good. So the respiratory rate's not too low, right? On the ventilator, respiratory rate set at 12 or 14 is like on a neuro patient. That's probably not great. Or you have a neuro patient that's not intubated, and I got pain, I got a headache. You're like, here's some morphine for you, and they're like not breathing, right? They're breathing like 8 now. That is hypercapnia. So we gotta, it's a fine line. It's like I'm gonna give you Tylenol first, see if that works, and then we'll escalate stepwise, right? If nothing else works, hey, do that one medication with a D. Anyways, we got when a fourth component, like a mass. Now we got not only 3 things, we got a mass in the way, right? We got a tumor that's developing, an intracranial mass of some sort. All right, so they have a tumor or metastasis that's developing inside, right? There's extra mass in there, right? So space occupying lesion is building up and building up. A tumor that's getting bigger and bigger and bigger, that can cause a rise in my ICP. Okay, so you can see here we got a tumor developing bigger and bigger until it starts causing a dramatic exponential increase in the ICP, and that's we've lost compensation. Our brain is no longer compliant to adapt to the increases in ICP. We're no longer able to auto-regulate the blood supply to our brain, and therefore the ICP goes up and we get symptoms because of it. And we kind of know some of those symptoms with herniation and such, but we'll kind of recap on those as well. Perfect. All right, so brain volume. So why would my volume go up? Again, it's not because they are more learned than the next patient. It's because they have cerebral edema that has built up. The brain has filled up with fluid, right? It's fluid inside the interstitial spaces, yes, but also in the cells, right? We kind of touched on this as far as like why it happens. We mentioned that we have inadequate O2 delivery, so there's no oxygen being delivered. Therefore, the cell membrane can no longer maintain its channels, its ion channels, and the sodium-potassium channels can no longer keep the sodium inside, or keep the potassium inside, and the sodium can no longer stay outside, so sodium just goes right inside, just like it wants to, and that's going to draw water with it, and it's going to start popping things, right? And that sodium-potassium channel is what creates a potential, right? A membrane potential, and the potential starts going higher and higher and higher because we can't maintain it. Now calcium channels get activated, and calcium can now come in, and calcium comes in, and starts hitting all the buttons, and apoptosis occurs, and glutamate gets released, and it's a bad downward spiral that we need to try to avoid by avoiding any kind of hypoxia, right? So the cell suicide or apoptosis occurs, and that can then lead to further damage, right? So now when the cell gets filled with fluid because the sodium was going in, but also the apoptosis caused a whole bunch of proteins to get released, right? And all these proteins cause the drawing in of water as well. So all that's going to then add to the cerebral edema. So our goal is to avoid that in the first place. If they're having seizure activity, we'll treat the seizures, but we want to, avoid any kind of further insults by avoiding any more hypoxia or low glucose or low blood pressure, because low blood pressure is also delivering the glucose and delivering the oxygen for the ATP to keep the channels at bay, right? So shock, cardiac arrest, any decrease in cerebral blood flow will cause a lack of oxygen and therefore a damage of the cells, and cerebral edema will then occur. The cells will start swelling, right? And then inflammation, so body-wide inflammation. So it's like an hepatic encephalopathy patient, right? A patient that has an infection somewhere in the body and they start getting confused. Why'd they get confused now? Because before they had an ammonia of 250. Why is it today that they have ammonia 250 plus confusion? It's because the blood-brain barrier got leaky, right? And why did it get leaky? Because we know when we have inflammation from sepsis, the vessels get leakier and leakier and leakier. Same thing with the blood-brain barrier. So now more things can get across, like ammonia, hepatic encephalopathy. But here we have other things getting across that shouldn't get across, and it starts causing more edema, right? Little proteins and other things, right? So, there's meningitis can do it, traumatic brain injury, right? Those blood-brain barriers are maintained with, with some integrity, but with traumatic brain injury, you can no longer maintain all those different molecules to keep everything at bay, right? And then fluid dynamics. So if we have, the blood-brain barrier is only as strong as you need it to be, but if you have an extra amount of fluid, it's going to start pushing its way through the blood-brain barrier. So hypervolemia can do it, again, especially with TBI, because the TBI can't keep everything operational at the blood-brain barrier, because it's damaged, right? The whole thing has been decimated, right? With a huge brain injury, whether it be a concussion or a contusion, to an axonal injury, to a hemorrhage, whatever it may be. All these things are impairing the function of the blood-brain barrier. Okay, hypotonic states can do it. We have hyponatremia. That's going to cause more fluid to go from the hyponatremic serum into the brain, right? Causing brain edema. And then we got vascular tonicity changes. So that means that we rapidly took out all the solutes from the bloodstream and you've made it hypotonic. And now the fluid is going to go where? Into the brain, right? Well, how does that happen? Well, it happens usually with first pass dialysis patients, right? They get this disequilibrium syndrome where we pulled all these urea molecules, right? All these urea proteins. We pulled all of them across the dialysis membrane. We pulled them all across, and we left the serum as hypotonic, right? The brain takes a second to equilibrate. They don't both equilibrate at the same time. So the brain's like where it was before, or at a certain osmolar concentration. But we drop the concentration, made it super dilute on the bloodstream side, and now all that fluid is going to try to balance somewhere, so it's going to balance into the brain, and they get this confusion post-dialysis, and a cerebral edema is what's going on. Okay, same thing with hyperglycemia. Like we mentioned with insulin drips, you bring the sugar down by 50 to 70 points per hour. If you brought it down by 200 points, right, you just dropped 200 glucose molecules into the toilet, right, or you pushed them into the cells, and now the brain didn't have a chance to equilibrate, right? So now the serum is more hypotonic than it was before, and all the fluid is going to rush into the brain, right? So that's going to be a reason for cerebral edema as well. The blood-brain barrier not being operational as well as it should, and the fluid shifts that are occurring. And we have metabolic problems. So the ammonia is leaking during a sepsis process, during a surge response of some sort, right? We have acidosis that impairs the blood-brain barrier from doing its thing to keep things at bay. Again, TBI could do it too, but it's more metabolic stuff, right? You got acidosis. We can no longer maintain these little proteins, right, that are keeping things, little struts and different things that are keeping the blood-brain barrier intact. But now little sepsis molecules getting through. There's septic inflammatory markers. All these things are leaking through at this point, right? And this is called a vasogenic edema. Right? Vasogenic meaning that it's the vessel delivery to the blood-brain barrier, the blood between the vessel and the blood-brain barrier is being broken down somehow. Remember we mentioned acidosis and temp. Those things are what keep everything operational in the body. If they denature, which happens with acidosis or temperature changes, then you can no longer keep things where they should be, right? One of the things being the blood-brain barrier. And alkalosis is the same thing as acidosis, right? But we can sometimes induce alkalosis with a CO2 that gets too low. So that's why we say the sweet spot is usually more than 28. So 28 to 35 is where we'll keep it, right? And if we really had to blow off CO2, we're not going anything less than 28. So you're going to make sure that they are normalized. Usually, like by default, 35 to 40 on the CO2. And if we really have a really high ICP, we'll kind of crank the respiratory rate up or the tidal volume up to bring the CO2 down to like 30 or so. Okay. Again, types, we got cytotoxic, that's where, vasogenic is what we just talked about, the blood-brain barrier being interrupted, right? The BBB is destroyed in some fashion, whether it be a traumatic brain injury or acidosis or fever, something is destroying the blood-brain barrier. Okay, steroids can help because steroids stop inflammation, so that makes sense. If this was because of a surge response, then maybe steroids might be beneficial. Tumors can start eating away at the vasculature and eating away at things and eat away at that blood-brain barrier, and therefore tumors might be responsive to steroids. It's a little bit debatable. Yes?
So is early extubation still something that we want to aim for with someone like this?
If they're stable, we can extubate early. So, does intubation cause these cerebral edema? Not really, right?
If we're like artificially lowering the BCO2.
Yeah, so if on the ventilator, if we are overdoing it, that's why we monitor end-tidal CO2, we monitor oxygenation and such, ABGs, to make sure we're not getting too overzealous, right? But they might need the ventilator for airway protection because they have like a severe bleed of some sort, or a tumor that's compressing their phrenic nerve or something, right?
But I mean, after we extubate, the body will equilibrate.
It should, yes. So that there's what's called autoregulation, where your brain is able to vasodilate, vasoconstrict at will, and that can recover with a couple of days after traumatic brain injury, for instance, or if the acidosis is improved or the sepsis is improved with antibiotic therapy. Then yes, after 2 to 3 days, we shouldn't have such a leaky blood-brain barrier or a blood-brain barrier that's intact.
Sorry, so if they were post CBA and we were keeping their PCO2 low with the ventilator, and they were extubated, would we be concerned about, obviously if their CO2 goes back up to normal, there will be ensuing encephalopathy, correct?
So yeah, so for a post-stroke patient and you extubated them and now you have no longer a control over their CO2 because you're making them a little on the alkalotic side, like 30 to 35 to 40. And then after extubation, are they at risk? Yes, because they could stop breathing. They could have these weird respiratory patterns where they have bradypnea or they have like Cheyne-Stokes or agonal breathing, or they could have pain and we give them pain medication, right? So using a little cannula with the end-tidal CO2 monitoring is good, right? Because we know that it trends the CO2. So having an extubated neuro patient is worrisome. Just like with a BiPAP patient, that's the sickest patient in the unit, really, right? Because when on the ventilator, you have control of the airway, you have control of all the values. Whereas post neuro patient that's extubated, yeah, you don't have complete control over everything. You get an ABG back and they're acidotic, like breathe faster. It's like they're not able to respond as well, right? And they might have to be reintubated at that point. Okay, no worries. So yeah, so vasogenic edema is where the blood-brain barrier is not working. And then we have cytotoxic edema. That's where the cells themselves are being destroyed. So like a lack of perfusion, like a stroke patient, right? So the cells themselves are being destroyed. So those little sodium potassium channels, the calcium channels, all these things are being destroyed, and they can no longer maintain their ion channels, their membrane potentials. They can no longer keep sodium outside the cell. So it goes in, draws in more fluid. Calcium goes in, activates glutamate. It's a whole cascade of events, right? And giving steroids here is known to be harmful. We know it's harmful in that situation. So all these things are raising the volume of the brain, right? We have more edema, more fluid going to the brain for some reason, whether it be a destroyed cell membrane or it be due to a blood-brain barrier that's not working. Okay. Sometimes what you'll see here is over here how that you see the nice sulci going in there. You can trace the sulci. Over here, you get a nice sulci can trend right there. So when you have edema, they lose that they have a loss of differentiation between gray and white matter. So what are you talking about? All right, so that means the sulci are no longer prominent on this side, right? You see the sulci are no longer prominent. That is a sign of cerebral edema that we can see on CT scan and we can see on MRI. Okay, so especially if someone has a conceptualopathy, the whole brain will be like this, not just one side. Okay, whereas it's like an ischemic change that we'll look at more in strokes.